Okay, welcome everybody. It's 4 p.m. in Argentina, it's 9 p.m. in Egypt. So I would like to welcome everybody to this session of sharing experiences managing patients with different ophthalmic conditions in between these two countries that I'm sure we will build up from here to have a stronger collaboration, scientifically speaking. The two countries are very similar. Argentina is bigger, but Egypt has twice the population. The types of patients that we normally see are very, very similar. So we see a lot of diabetic patients, some very hard cases of uveitis as well. So we have selected a group of the top-notch speakers within the two countries to have this session and share experiences with us. We have Professor Moghazi as a co-moderator on the Egyptian side, who will be doing all the introductions. We have a selection of videos and cases to be presented. This is being transmitted via YouTube. Within YouTube, you have a chat box. Please type all your questions within the chat box, and we will be picking up these questions after all the presentations are done. And so we can go through all the questions and answer the questions within that session. So having done all the introductions for all people viewing it from Argentina and other countries within Latin America, and I'm sure within the Middle East and Egypt, there are several other speakers as well. I'll pass on to Professor Moghazi, who will do the introduction on his side and start with the first presentation of the first speaker. Thank you very much.
Thank you, Professor Schlottmann, for this introduction, and thank you for inviting the Egyptian side to share with you in this retina extrema. I guess this means extreme retina, and it's really an interesting idea that you introduced to me. And today is the first collaboration between the Egyptian team, presented by Mohamed Salah, of course, and the Argentinian team presented by Messi. And it's not a fight, it's not a competition, it's just sharing our cases together. And I think this is a good start for further collaboration. So without further delay, I would like to introduce Professor Hani Hamza, who is a professor of ophthalmology and a vitreoretinal surgeon in Cairo University, who is gonna present to us a very interesting topic about FEVR, or familial exudative vitreoretinopathy. And of course, this is not the usual bread and butter of the vitreoretinal surgeon, but Dr. Hani Hamza, of course, is one of the leading pediatric retina surgeons in Egypt, and he's going to give us his views about how to go through those cases, the grading system, and how to manage each, and how to follow up those cases. So please, Professor Hani, please go ahead.
Thank you very much, dear Mohammed, and I would like to welcome Professor Schlottmann and my Argentinian colleagues. It's my real pleasure to participate in this webinar. So I'm going to start with the topic of familial exudative vitreoretinopathy, or FEVR. What's the technique to be used surgically, and what are the limitations? So, yes. Historically, FEVR has been described by Criswick and Skippins, and it was called actually Criswick-Skippin syndrome in the late 60s. And it's a disorder of the retinal vasculature, characterized by abrupt cessation of growth of the peripheral capillaries, which causes an avascular peripheral retina, in turn peripheral retinal ischemia and hypoxia with compensatory retinal neovascularization, leading to rupture and these new vessels with exudates and bleeding, and finally scarring and retinal detachment. So it is one of the retinal vascular disorders like diabetic retinopathy and retinopathy of prematurity, but with special characteristics. FEVR has been classified by Pendergast and Tracy in 1969, and this classification has been simplified again in 2011. As you see, we have 5 stages. Each of one is classified into A and B. A and B actually refers to the presence or absence of exudate in the case, except in stage 5, where it refers to an open or closed funnel retinal detachment. In stage 1, we have an avascular retinal periphery, and these cases can be managed by close observation. If the case proceeds to stage 2, then we have extraretinal neovascularization, and here we can use laser plus minus anti-VEGFs like ranibizumab or bevacizumab or others, or Eylea even. In stage 3, we get a retinal detachment but extramacular, and here we can do scleral buckling plus minus vitrectomy if the detachment is threatening the macula. In stage 4, we have a retinal detachment involving the macula, and these cases should be managed by vitrectomy, as we are going to show you now. And finally, we have the stage 5 with retinal detachment, as we said, and it refers to open or closed funnel retinal detachment. What are the diagnostic criteria for fever? Lack of peripheral retinal vascular development in at least one eye. There is no history of prematurity whatsoever. Variable degrees of vitreoretinal traction, subretinal exudation, or retinal neovascularization, and it can present at any age. I mean, we can see an adult who is presenting with manifestations of fever at the age of 25, 30, and 35 years, and he has never complained before of anything in his eye. So retinal detachment and fever is a common finding present in 21 to 64% of cases, according to the literature that has reported. It may be tractional, serous, and it is called familial exudative vitreoretinopathy, so the serous component is quite significant. And finally, we have the rhegmatogenous component, which is usually a combined traction rhegmatogenous retinal detachment. Now, in advanced traction retinal detachment, there is a very characteristic finding in these cases, which is the falciform or knife-like retinal fold, extending from the optic disc to the retinal periphery and can even reach to the ciliary body. It's one of the classic features of severe fever, and you can see, by the way, a similar fundus appearance in Norris disease and osteoporosis pseudoglioma syndrome, and actually there is a genetic linkage between these diseases and overlap genetically between them in the genetic defect. So what are the indications of vitrectomy for fever? It's a traction retinal detachment involving or threatening the macula, as well as a traction rhegmatogenous retinal detachment. So let's go through the first case. This is a 6-year-old girl. She has a left eye stage 1 fever treated by laser, while in the right eye she has a stage 3 with traction threatening the macula. You can see the fibrous tissue and the fibrotic vitreous, as you can see. In these cases, I have noticed that the vitreous transforms rather into a fibrotic membrane, as you will see in 2 other cases. Now I am releasing the central traction from the peripheral one, and I'm trying to trim the peripheral traction in the extreme periphery, and you can see the proliferation on the optic disc and extending over the macular area. Now this traction has been released, and I am moving very cautiously in order not to create an iatrogenic break to trim this fibrous tissue on the surface of the retina. And at one point, I have a clean posterior pole. I injected triamcinolone to make sure that there is no vitreous cases or an adherent layer of vitreous. And actually, in many of these cases, you have a posterior vitreous detachment if the case is relatively old enough. Now I have decided to try to peel the ILM. And as you can see, it is quite difficult. I'm using first a Thanos scraper, and now I'm using the forceps, and you can see the whole retina moves with me, and it gets out into piecemeal shreds of the ILM without being able to remove the ILM completely. So I decided actually to stop at this point in order not to create further damage and to move doing a bimanual dissection to clean up the retinal surface, especially in the area close to the macula, using the scissor and forceps and the chandelier light, as you can see, to release the central traction, as you can see. Now, removing the central traction, I have achieved my surgical goal. You can see the area where I have tried to peel the ILM, where the retina looks edematous, and actually one of the conclusions that I should not attempt to peel the ILM in these cases, as it is quite adherent. Now, this is a more difficult case. This is a 9-year-old boy presenting with atrophia bulbi in one eye, and in the right eye, a stage 4 with traction on the macula. You can see the whole vitreous has transformed into this fibrotic membrane, and I'm now trying to separate the central attachment from the peripheral one, and I have this falciform fold, but actually it's in the superior retina, not the temporal one, and you can see 3 layers of fibrous tissue inserted into the retina, into this falciform retinal fold. Removing the vitreous on the macula and doing bimanual dissection to release the peripheral traction. And now I'm dealing with the falciform fold and the fibrous tissue on it. I decided to segment it first, and then I'm moving again and using the bimanual technique until I could dissect this fibrous tissue to the periphery. I have some bleeding at one point, and removing this last piece of fibrous tissue on the optic disc. Actually, during this section, I created an iatrogenic break in the upper retina in this case, and I had to use cryo to close it and use silicone oil. You can see the abnormal vasculature in the periphery and the dilated capillaries and the exudate, and I did cryo over this area as well, and endolaser. When I tried to remove the silicone oil in this case, I tried to remove it 2 times, but actually the patient was developing redetachment on table because the upper break could not close. So one of the very serious complications in these cases is to have an iatrogenic break. And this is something you have to avoid by all costs. Now, this is the last case I'm going to show you, and maybe this is the last one. Yes, this is a relatively early case. You can see that the fibrous tissue over the macula can be removed. And here the hyaloid was attached, but easily detachable from the retinal surface, a bit adherent on the optic disc. Again, cleaning the vitreous up to the periphery and trimming and shaving of the peripheral vitreous. And one of the things is that post-operative, these cases can develop an exudative retinal detachment. So don't confuse it with the rhegmatogenous one. This is the response of the eye to surgery, and usually it settles in a few months. So what have I learned from these cases? Actually, I have 6 golden rules to convey to you in these cases. First of all, you have to release the necessary traction only. Don't overdo it. Otherwise, you will be creating an iatrogenic retinal break. Rule number 2 is that retinal folds cannot be unfolded. These knife-like folds and chronic folds with traction cannot be unfolded anyway. So just leave them and they will remain like that. Rule number 3, that the membranes may be amalgamated to the retina and there is no clear cleavage plane. Again, I repeat, do not create iatrogenic breaks or retinotomies. Retinal memory will keep them open despite retinopexy and whatever you do. Number 5, in early cases, PVD is absent, but later you may have a PVD, but the vitreous is transformed into this multi-layered fibrotic membrane that you have to trim everywhere in the vitreous. And finally, the ILM may be difficult to peel, so do not insist on doing this step. It is not even necessary in these cases. To conclude, fever is a lifelong disease. It can progress, resulting in blindness despite treatment. Although familial, the phenotypic features can still be variable within families, and you have to screen the families. And vitrectomy for fever is a difficult surgery, but if you follow these basic rules, you can get a successful result. Thank you very much.
Professor Hamza, thank you very much for that. Very interesting cases, very good quality videos as well, and the 6 golden rules that many of the surgeons are taking home with them. The next presentation is going to be on the Argentinian side of the team. We're going to have Martin Charles. He is a well-recognized surgeon. He's got a few of these good videos from the ASRS, prizes for great videos. And he puts a lot of time into making sure the quality of the images are great. And he's also one of the greatest surgeons here in Argentina. So Dr. Charles, he's going to be presenting about retinal detachment and PVR, so we can see his approach and his pearls for those of us doing this type of surgery. Martin, all yours.
Thank you, Patricio. Can you hear me?
Very well.
Okay, great. So I will talk about surgical technique in retinal detachment and PVR. How do I use it? So it's important to, nowadays we have a lot of instruments, wide angle viewing systems, high velocity equipment, probes, and these new shaped retinal probes and chandelier illumination. So they help us a lot. So this patient is a giant retinal tear. I approached the surgery via 3-part plana evolved trocar cannulas, 25 gauge, and a 4th entrance for the chandelier. I like to place the chandelier in between my 2 hands in hour 12. So I start the surgery by a core vitrectomy. it's very important in giant retinal tears to take all the vitreous, but here we continue all the retinal tear, all the little attachments to the periphery. So we make a big tear. The nice thing about chandelier illumination is that we can auto-indent the sclera, and in that way we have a really good vision of the periphery, and we can handle all the vitreous base and perform a really good vitrectomy on the vitreous base, as we can see here. How I set the equipment: I use the Constellation Vision system, as most of you use. So I go on the setting, proportional vacuum, and the highest cutting rate that I can. In this case, I'm using 10,000 cuts per minute, so my whole surgery is on that cutting. Look here how the auto-indentation helps us to reach a little tear under applied retina. When there's a little membrane that we see on the OCT, on the pre-surgery OCT, so if we see a little contraction of the epiretinal membrane, so I stabilize the posterior pole with perfluorocarbon liquid. I do endophotocoagulation, and on the places I cannot reach, I use also auto-indentation. Look how we do all the laser on the periphery of the giant retinal tear. It is very important, if we pass with the PFO, it's very important to have the retina, mobile retina. This is the post-operative images. I left gas C3F8 at 13% without scleral buckling. So this is 4 months post-operative. Now I will show you some surgeries about PVR. This is a paper that we wrote with Aníbal Francone, who is working with me, and Alejo Capriroli, and we have just submitted this to this year ASRS meeting. There are 11 eyes of 11 patients that underwent PVR surgery, and the idea is a novel idea where we do an extensive ILM peeling so as to get rid of the epiretinal membranes and to lower the risks of reproliferation. This is really lovely, and I will show you 2 cases where I explain the technique. This is a case where a very good surgeon had a little fragment. He did a cataract surgery, a little fragment of the nucleus dropped into the vitreous cavity. He got rid of it, but later epiretinal membrane was there. So I did the surgery. It went really well, but 1 month later, the patient had a detachment due to PVR. So here I will explain the technique. The idea is to perform a vitrectomy. The same, three entrance and a 4th for the chandelier. Look here, the posterior pole is rid of ILM because we took it out on the last surgery. But the idea is to stain and stain and stain and go and peel the ILM from the posterior pole to the periphery. And the idea of peeling the ILM is that we make the retina more mobile, and also the ILM is all the membranes develop over the ILM. So if we took a cleavage plane and we take the ILM, we will look for the natural cleavage plane of the epiretinal membranes that are lying over the ILM. So it is really lovely. One of the key points is to have a really good visualization, because here we are performing the peeling under the biome. And here I do like a bimanual approach. In one hand, I have the diathermia, and on the other hand, I have the Peters probe performing the retinotomy and doing selective diathermia on the bleeding vessels. Under PFO, I stabilize the retina and the posterior pole. I do a fluid air exchange, endodrainage through the border of the retinotomy, aspiration of PFO and air silicone exchange. This is 50 days post PVR surgery, and here is the image of all the retina attached under silicone oil. 10 weeks later, I performed the silicone oil extraction. This is my technique. I put the last entrance with a non-valve trocar. This is a special cannula that comes with the viscous fluid control pack for the constellation. So we perform an active aspiration of the silicone oil. The idea of using this blue cannula instead of the cannula that are used for injection of silicone oil is that with this cannula we have a much better flow, and the silicone oil extraction is very fast. I exchange the non-valve cannula for a valve one, and then we perform 2 fluid air exchanges so as to get rid of all the little drops of silicone oil left inside the eye. So I start the maneuver with a blunt tip cannula without the soft tip so as to have better flow. And here we can see the projection of this little drops of silicone oil over the retina. They're actually floating over the BSS. And so we perform a fluid air exchange, air fluid exchange, and as to avoid to have a jet effect damaging the retina with the cannula, we try to go on the line of the jet effect so as when we do the maneuver, it doesn't hurt the retina with iatrogenic retinal tears. We do another exchange, and the surgery is done. Here's the postoperative photograph with all the retina attached under BSS. So this is 6 months post silicone oil extraction. And the last, and this is the OCT with a really lovely macula. The last surgery is a patient that had a PVR. This patient came late to eye examination. He had lost the vision some months ago. I used to perform nowadays a lot of combined procedures where a cataract is present. I like to perform cataract surgery and retina surgery at the same time. So when I do combined procedures, I like to first get rid of the cataract, like a simple cataract case, and then I start all the maneuvers to perform the vitrectomy on the same time. So I place 4 entrants with 25 gauge valve trocar cannulas. We start the vitreous removal, like a core vitrectomy. Look at the settings of the equipment, the highest cut rate possible, and proportional vacuum. Always with a chandelier that gives a really lovely image with the auto indentation. I have a good visualization of the periphery and get a really lovely vitreous space shaving. Then we start with the ILM peeling on the posterior pole. When it comes really easy, I leave the PFO for later, because when we have the PFO, it's much easier to peel the ILM, but we have to get rid of it and aspirate it when we want to restain. So sometimes it's easy to peel the ILM without PFO. Sometimes it's better with PFO. So here I injected PFO, and with the biome visualization and serrated forceps connected with the pneumatic handpiece, I start the ILM peeling in the macular area, and then we go to the periphery and we stain and restain. And the good thing about this technique is that the ILM lies underneath the epiretinal membranes, so it's a really lovely and natural cleavage plane, so as to find and get rid of the epiretinal membranes that are inhibiting the retina for having a mobile retina. The visualization is a key part for this surgery, because it's not very easy to peel the ILM when we go further over the posterior pole. So we do another vitreous space shaving. Look at here, the retina is really mobile. And in all the cases, I do not put a buckle or a band. This lovely visualization is due to the chandelier illumination. So I have one hand that is free, and with that hand we can perform outer scleral indentation. Here we have PFO on the posterior pole. We perform a fluid air exchange. With a soft tip cannula, we aspirate the subretinal fluid through the retina tear until the retina is dry. Then we go and aspirate the PFO near the optic nerve. And then we perform endolaser photocoagulation. Nowadays, we also have lasers that come with endoillumination, and they're really lovely. So look at the good visualization that we still have with this patient that we perform a cataract surgery on the same day. This is the first day post-op images, the OCT, the wide image fundus at 2 weeks with 20/60 visual acuity. And this is the image after silicone oil extraction with a good, with a retina attached. So the keys are extensive red and blue G staining, create a cleavage plane for FEVR membranes that could guarantee its removal, stabilize the posterior PFO, bimanual retinotomy, selective diathermia, and silicone tamponade that can last between 8 and 12 weeks. So the good thing about this is that the ILM is the natural cleavage plane that can make an easy removal of the epiretinal membranes that are lying above the ILM. So in summary, all these new things can give us much better image visualization, and they can help us to be to have more accurate and reproducible surgeries and have better outcomes. Thank you.
Thank you very much, Martin. That was a great presentation, good quality videos and good tips for those seeing these type of patients. So now there are some questions coming, which we'll be answering the questions at the end of the session. So when we reach the end of the session, we're going to start reviewing all the questions related to each of the videos, and then each of the speakers will resolve and explain and answer these questions. So now it's my great pleasure to present the next speaker, who's on the Egyptian side. He is a very good friend of mine. He's Professor Mohamed Moghazi, and he's going to be talking about myopic traction maculopathy. Professor Moghazi, he's professor of ophthalmology and vitreoretinal consultant at the Ain Shams University in Cairo, Egypt. We have shared several educational events in Egypt and other countries as well, and we meet regularly in different places of the world, and it's always a pleasure to listen to his presentation. So Professor Moghazi, great pleasure to see your talk. All yours.
However, this is kind of common in Egypt with the population of high myopia that we're having here. And this specific entity, the myopic traction maculopathy, has come into focus lately with a lot of hot topics regarding the way to manage those cases. So just a theoretical background, it's found in about 9 to 34% of high myopic eyes. And it usually shows progression. And according to Shimada et al., who gave the first classification of such a disease, it can range from stage 0 to stage 4. Stage 4 is the one with foveal detachment or impending macular hole. Usually, immediate surgical intervention is not necessary, and surgical intervention may be indicated of cases of progression of these cases or drop of visual acuity in extensive S4 myopic stages to prevent the development of a macular hole or foveal detachment. However, secondary macular hole is one of the devastating complications, whether of the disease itself or of the surgery. And the incidence of macular hole development is up to 27%. Risks include severe foveal detachment, like you can see in this picture here, or cases with inner and outer segment junction defect. Post-operative full-thickness macular hole occurred in 13 to 28% of the cases. This is still a very high percentage of cases that also still develop macular hole after the surgery. So the treatment options for this disease is either observation, and this is reserved for the early cases with limited schisis, let's say stage 0, stage 1, 2, with good visual acuity because of the high risk of complications of doing the surgeries in those patients. I guess observation is key in those patients, but close observation. Vitrectomy is indicated in the more severe cases, and the main stay in the vitrectomy for those patients is how to handle the ILM. So several techniques have been described with no ILM peeling, with complete ILM peeling, or with foveal sparing ILM peeling, which is currently my favorite technique. So let's navigate through some of these treatment options. So observations, in the cases observed, according to Goucher, 2/3 of the cases worsened if left untreated, and that's the key, when to intervene and at which stage of the disease you intervene, just to preserve the vision and avoid the development of a macular hole. So this is a case I have been following since 2013, and this is just a stage 1 myopic traction maculopathy with an excellent visual acuity. And by the way, the other eye of this patient, the right eye, had a chronic macular hole, myopic macular hole without detachment, and the visual acuity is 2400. So this is his good seeing eye, and it's 2040 at this stage. And in 2016, 3 years later, he developed probably an acute PVD with the development of a full thickness macular hole. Macular hole surgery was done. I'm not going to show you the surgery because this is not the topic, but to show you that visual acuity was 2040 before the macular hole development and 2100 after the macular hole was closed by the surgery. This is again because this patient we observed for so long waiting for a macular hole to happen. So he never regained the original visual acuity of 2040. Let's see some surgical cases. This is a case where I've been following since 2012 with 20/60 vision. And again, this other eye, the other eye of this patient has been lost to a failed macular hole surgery, myopic macular hole surgery. And she came in 2016 with a drop of visual acuity with progression of the schisis cavity. And you can see here also a foveal detachment. So I decided to go into surgery. This was some time ago, and I only decided to remove the posterior hyaloid, which in such cases of high myopia should always be done using triamcinolone staining. I only removed the cortical vitreous as much as I can and as safely as I can, not to induce macular hole. Again, under high magnification using the contact lens for the macular surgery. And this is post-operatively, you can see a dramatic improvement of the schitic cavities, but unfortunately, this patient still developed macular hole after just removal of the posterior hyaloid and leaving the ILM without removal. So schisis cavities collapsed, but the patient developed a macular hole, which was later on treated by inverted ILM, and still the visual acuity, however, is poor. This is another case, stage 3/4 myopic traction maculopathy. And this patient, while I was removing the posterior hyaloid, triamcinolone assisted, I discovered that I accidentally removed the ILM completely as I stained and restained, and the ILM was not there. So in some cases, as you all know, the posterior hyaloid is very tightly adherent to the surface of the retina, that when you remove the posterior hyaloid, the ILM is removed as well. So this is a case where I accidentally removed completely the ILM. I guess I was lucky in this case because no macular hole developed, and actually the visual acuity improved after 1 year to 20/80 with, of course, marked improvement of the macular architecture and resolution of the schitic cavities. This is another case where the ILM also was completely removed. This before I adopted the technique of foveal sparing. And the ILM, you can see, is also very tough in those myopic cases and very tightly adherent to the parafoveal blood vessels. And it was completely removed in this case. Again, I was lucky, and this patient improved post-operatively to 20/40. And I guess the two cases that I just showed to you now with complete removal of the ILM, the one accidentally and one intentionally, they did not have a preoperative foveal detachment. And this could be the key in those cases, that they did not develop an intraoperative or postoperative macular hole. So maybe it's safer in cases with no foveal detachment, no pre-existing foveal detachment, or to do just a complete ILM peeling. This is another case with 2200 vision. You can see this is an interesting case actually, because it was diagnosed elsewhere as having macular edema, and was treated twice with Lucentis injection. So when she came to me, I told her this is myopic traction maculopathy and never an edema. And this is one of the commonest mistakes that in my country. We see a lot of cases that doctors rely on the OCTs rather than investigating the whole case as a whole. And when it's written macular edema, they go ahead and inject those patients. So I decided to do foveal sparing ILM peeling in this case after removing, of course, of the posterior hyaloid, again, triamcinolone assisted. And the original technique of foveal sparing was described by Shimada et al. In 2012. However, in this technique, I modified a little bit. The original technique described leaving like a donut of ILM all around the fovea. But I decided to just detach the ILM as far as the edges of the fovea and leaving just shreds of the ILM just to help further relaxation of the surface of the retina. And of course, the rest of the ILM, as far as you can go safely, is removed, and the parafoveal or perifoveal ILM is just trimmed and left as is. This is 1 month post-operatively. You can see here the residual ILM over the foveal area. And you can see this is the preoperative and this is the postoperative. You can see quite a nice collapse of the schitic cavities. Still, there is foveal detachment, but actually it improved over a year with no concurrent improvement actually of visual acuity. This is another case, 2200 in 2016, and was treated repeatedly for a myopic CNV. You can see an active myopic CNV here, was treated repeatedly, and the myopic CNV actually regressed. However, the patient in 2018 came with drop of vision and such a huge schisis and foveal detachment. So I decided to go in for surgery. Again, in this patient, I decided to go for the ILM sparing technique, and again, the modified technique from the original one, with just leaving the ILM detached till the center of the fovea, without leaving a complete attached part or a complete attached disc over the foveal area. It's not easy, and in some cases it's really tough. Like you see here, the ILM in those patients is really kind of plastic, not elastic, and you can easily create a break. So you have to be very careful. You have to be able to visualize well the retina, not to create an extra foveal macular hole. And this is an amazing result for me, 1 month post-operatively, with complete collapse of the schitic cavities and no macular hole. And you can see here the residual ILM is seen on the OCT, with a concurrent improvement of visual acuity in spite of the residual scarring of the old myopic CNV. This is, I think this is my last case I'm going to show you. This is again followed up in 2016, 2017. Visual acuity dropped from 2100 to 2200 with exaggeration of the schitic cavities and start of foveal detachment. And this patient again had previously treated myopic CNV. This is in 2018 with foveal detachment, and at that stage I decided to go in again, and again using the foveal sparing ILM technique, ILM removal technique. Same thing. Just trying to not to go too further in at the edges of the fovea, not to create a hole myself, or not to lose the ILM while doing that. And then the rest of the macular ILM is removed. And this is post-operatively. You can see here, 1 month post-operatively, there is good collapse of the schitic cavities, a decrease in the foveal detachment, which has also improved over 3 months post-operatively. Again, the vision is the same, but we did not develop a macular hole, and this patient actually continued to improve over time with minimal improvement of visual acuity. So in those cases I presented to you, TA was used to stain the posterior hyaloid in all cases. I did not use the original Shimada technique of leaving a donut of ILM over the fovea, but I just tried to separate the ILM even in shreds, leaving it attached only at the edges of the fovea. A contact lens is a plus in those cases because it gives you higher magnification and the better depth, but I also use the central indirect viewing system lens in some of those cases. With those with large posterior staphyloma and wide reflex, I guess a contact lens can be helpful. No tamponade is used at the end of all of those surgeries. Actually, I used to use SF6 before and air. However, I did not find that addition of air or SF6 can actually fasten the resolution of the schitic cavities or improve the overall outcome of the surgery. So I just leave them fluid-filled or on BSS. So in conclusion, close observation may be a good option in some cases with early myopic traction maculopathy and good visual acuity. However, you have to instruct the patient to come at the immediate signs of any drop of vision. Most of those patients are one-eye patients, and I guess they will come when they feel there is any change. Of course, regular follow-up with OCTs is also important. Different ILM handling techniques are key. And as I showed you, if there is no foveal detachment, maybe you can get away with complete removal of the ILM. However, when cases where there is a foveal detachment, high schitic cavities, high risk of macular hole development, I guess the foveal sparing ILM technique is a key in those cases. Thank you very much.
Thank you very much, Professor Mogazzi. That was a great talk. And these are usually very difficult patients to manage. And these are the retinas that most surgeons don't want to get into, because if you do it wrong, that goes the retina away and there's no way to fix it. So those videos were great. And the final tips, I'm sure they're going to be very important for all the viewers. So our next speaker is going to be Dr. Rodrigo Santos here from Buenos Aires. He's a very experienced surgeon. He's going to be talking about PDR and the management of PDR. And he is a surgeon that receives many cases from doctors that have tried, failed, and then the second chance is given on his hands. So I'm sure he's got some interesting cases to be presented, some rough cases as well to be presented here. So Rodrigo, all yours. Thank you very much.
Thank you, Patricio. Let me see my video. Sergio, do you have it? Here. Oh, espera. Okay, perfect. No, pasalo para atrás y congelalo. Dame un minuto. Okay, well, thank you, Patricio. Look, I work as some kind of freelance surgeon, and I used to work in 7 different clinics. So that the way that I try to have a practical approach for each surgical situation that I had to face. PDR is not an exception, even though it sometimes represents a special challenge. Ahora sí, play. So, diabetes, as we know, is a systemic pathology with variable ocular manifestations. So I first try to make focus in patients' understanding of the severity of the situation and the need of treatment. I make emphasis in the metabolic status and the evaluation of the bilateral compromise. If the bilateral need of surgery, I always try to prioritize the better eye. I never get in a hurry because PDR is not an emergency, even in the presence of the retinal detachment. And for the post-op period, I try to leave a clear message about the timing of the expected visual rehabilitation, the need of retreatment in some cases, and the importance of a tight metabolic control. So the goals in model ocular surgery are focused in reducing time of the surgery itself, in making procedures simpler, and improving the efficacy, all of which will impact in cost, morbidity, and finite visual acuity. I like to call that procedures minimalistic procedures. We can achieve that goals reducing equipment needs, reducing the number of instruments that we are going to use, and reducing the number of intra and extraocular maneuvers. As I told you, I don't like surprises, so what I look before I plan a surgery in a diabetic patient is intensive metabolic control. I always inject anti-VEGF in the preoperative period, no matter what. And I evaluate the need of a cataract surgery. If I consider to do a cataract surgery, if it is possible, I try to do it before the vitrectomy, possibly when I'm injecting the anti-VEGF, 5 to 7 days before the vitrectomy. And if I have the chance, I prefer to go to an early vitrectomy. Stop the video? No, I hear the video. So as I told you, I choose, if I have the chance to choose, I prefer to go to an early vitrectomy. Remember that the prognostic factors, the main prognostic factors, are the preoperative visual acuity and the central macular thickness. And if the patient has a vitreous hemorrhage, I try not to wait too long. I try to do the surgery within the first 30 days. So now we are going to see some videos of PDR and my approach. So in the first patient, you are going to see a PDR. Look the aggressive laser photocoagulation that the patient has. It was referred to surgery because of the vitreous hemorrhage. I try to use only 1 or 2 instruments. In this case, I am using only the vitreous cutter to delaminate, to peel, and to segment the membrane. Try not to make much stress in the underlying retina. using the cutter on and cutter off option of the foot pedal, and using the alternative pressure to intraocular tamponade in a case of an event hemorrhage. One way to avoid the hemorrhage during or the bleeding during the surgery is to put the anti-VEGF a week before the vitrectomy. Once the posterior porus is clear, I will proceed with to complete the posterior vitreous detachment and the peripheral vitrectomy. And the surgery is almost done. In this next video, you're going to see a patient with an atrophic, very adherent fibroblascular membrane and a macular hole. I love to use this kind of spatula to look for a cleavage plane and to delaminate the retina and the membrane. So then the segmentation is much easier. The virtue of this spatula is that it makes some tangential traction. The tangential traction is less stressful than the anterior-posterior traction, or the traction that is produced by a forceps. And once the membrane is free from the retina, I just only proceed with the vitreous cutter to eat the membrane, to segment it, and to peel it near the optic nerve. Look that with only 2 instruments, we can work in all the fibrovascular tissue. This next step is only to work in the macular hole. I use Brilliant Brew Dual for staining the ILM epiretinal membrane complex, if you want to say that. And I love to use this kind of forceps. This is a Hassan forceps, but every ILM forceps works perfect. Now, a third case that is going to be a more complex case, the kind of cases that I want to deal with. This is a patient with intense fibrovascular proliferation and a mixed retinal detachment. So I choose in these cases to a bimanual approach with a chandelier, the spatula in one hand and the vitreous cutter in the other. I proceed with segmentation with the vitreous cutter and the lamination with the spatula. But there is an adherent membrane to the optic nerve, so I have to use a forceps. So the idea is not to wait too long to have to deal with this kind of patients. Even though the surgery is going to be nice or fine, this patient probably never is going to have a good visual acuity. Perfluorocarbon liquid, dissection of the peripheral proliferation. Now the air fluid exchange, endolaser, and silicone oil for this case. So the idea here is to try to avoid these cases, try to refer the patient at an earlier time. And the last case, look, this case is a patient with a proliferative PDR and a intense laser photocoagulation, confluence in some zones and none in others. So it's a bad done photocoagulation that was referred to me because of a vitreous hemorrhage, not because of the proliferation itself. So now we are going to see the surgery. Again, a vitreous hemorrhage. I try to leave all the vitreous cavity clean. So next, I can abort the membrane or the proliferation. Again, with the spatula, I can get really easy under the fibrovascular membrane to create a cleavage plane without too much traction or stress to the retina. The blurry vision is because of the blood. And again, vitroscatter, segmentation, and membrane extraction. I tried not to use endodiathermy or forceps or scissors. I tried to manage it with just a few couple of instruments. So, in PDR, good visual results will depend on the timing of the vitrectomy. Early vitrectomy is better than late. Prevention means tight metabolic control. Sometimes less is more. I try to avoid aggressive laser photocoagulation. Maybe it is better to combine treatments, for example, with anti-VEGF or early vitrectomy, because this is the only way to avoid facing these heroic procedures. So thank you very much. That's it, Sergio.
Okay, thank you very much, Dr. Santos, for this presentation and very nice tips for how to manage and approach cases of diabetic retinopathy and not to leave them way too long. Next presentation will be by Professor Ahmed Souka, Associate Professor of Ophthalmology in Alexandria University. And Professor Ahmed, as always, has his own ways of interpreting data from randomized clinical trials. He has also several publications in the field of medical and surgical retina. And today, I'm sure he's going to present us with one of his non-orthodox ways of treating or approaching a case, a medical retina case. Professor Ahmed, please go ahead.
Yeah, thank you, Professor Morazi, for giving me this opportunity to share with Argentina. And I'm a big Messi fan, and I do love Argentina. Actually, it's like my second country. I really cheer them everywhere, World Cup and stuff like that. And I also extend my thanks to Dr. Schlottman, a previous colleague and collaborator in previous conferences. You asked me to present something that shows how we deal with such cases as regards my approach to a certain case. So I decided to choose myopic CNVs because it has a different way of handling injections protocols in such cases. And I developed this experience, in a way using studies, but I'd like here to share my own personal experience over the years of how to approach such cases. And I'd like to mention it's common to have pleasant surprises in myopic CNV cases, unlike CNVs in age-related macular degeneration patients that really need more attention than myopic cases. However, I think myopic cases are generally common. And I'm presenting here the history of few cases over 10 years ago and how this modified the way of think about myopic CNVs. So this is a case in 2009. And as you can see, it's just a female patient, had refractive lens exchange for her myopia. She's pseudophakic at the time. And the visual acuity dropped 7 months earlier than her presentation to me. And she was advised by many other doctors not to inject. Remember, this is 2009, 2010, because this is a guarded visual improvement that will probably not happen. So everybody told her you don't need to inject. And she was presented with visual acuity of 0.2, around 624, in March 2010. With counseling and the presence of anti-VEGF at the time, okay, we decided we go to inject and see we had not much to lose at the time. So we decided to go for injection. This is the OCT's pre-injection. As you can see, it's just fusiform CNV at the level of RPE with overlying mild edema. Usually it's very mild in myopic cases, as we all know. And after 1 month of injection, visual acuity improved to 0.4, which is better than the previous visual acuity. And we decided that this is fair enough and we'll monitor what happens. 7 months later, it's a bit better to 0.5. The patient's happy anyway, feels fine, she feels it's good that she injected. 10 months later, after the injection, visual acuity improved further to 0.6, which is much more than her earlier 0.2 at presentation. For the patient, she was very happy. And at that point, I knew that patients improve over time. Another female patient at the time, in actually 2011, I think, a female, phakic, having a myopic CNV, everybody advised not to inject because visual acuity is in the area of 2600, which is less than 0.05 on the Snellen's and decimal visual acuity charts. Very low visual acuity, prognosis probably guarded. So everybody said, don't inject. The patient actually was pushing for, why don't we try it? And I thought, yeah, why not? It's just an injection. And she improved in 1 month only after the injection to 0.3 vision in the area of 20/60. This was actually astonishing and pleasantly surprising. Later on, I had more and more cases showing this favorable response. And as we all know, in randomized clinical trials like Mirror study recently, aflibercept used, and you can see that the median number of injections from weeks 0 to 8 was only 2 injections. And the median number of injections in cases after the 3rd month from 12 to 44 weeks was 0. So we know we don't inject a lot in myopic CNVs, which is much different than age-related macular degeneration that requires always injections. So how do I treat my myopic CNV cases nowadays? And I'll show you a recent case. I use PRN from the start. You just inject once and you see what's going to happen. You don't inject more, except. So we just wait after we inject, and before adding any injections, as long as the visual acuity is improving, monthly increments, even 2 monthly, better vision, I just wait. I don't inject more, and I usually end up with a very high vision. I only add more injections if the OCT is showing activity, more retinal edema, patient not improving, complaining, I'm repeating OCT to have a look, and I don't like the retinal edema. Otherwise, I don't really go for a rapid second injection. Cases now with low visual acuities under 2400, I still go for injections with counseling of the patient that this is not sure, it's not a guarantee that you will improve, but because I've had really a lot of cases that showed surprising improvement, I advise a single injection in neglected low visual acuity CNVs. Another point to mention is that the recent metamorphopsia, even with no findings on OCT in some myopic CNVs, do show a good response in vision and abolishing the metamorphopsia. And I had a few patients that insisted that they want the injection because they feel it, and I don't have any finding in OCT, and they did improve and the complaint was gone. So this is the recent case I'm going to presenting to me this year in early 2020. And she had bilateral CNVs, both eyes, a very old refractive surgery, 15 years old, refractive lens exchange, a pseudophakic patient. One eye had visual acuity of 2600 in the area of 0.03, let's say. The left eye had the visual acuity of 0.3, which is generally good, better seeing eye, neglected for a few months, 7 to 8 months. Nobody wanted to inject. They felt it looks reasonable. This is the left eye. As you can see, there is a bump in the central area, and OCT scans show the fusiform RPE lesion with overlying minimal retinal thickening of the already thin retina, a common finding in myopic CNVs, and vision in the area of 0.3, more OCTs, radial scans, and you can see that this is a definite myopic etiology CNV. We went for an injection of aflibercept, improvement in the first month to 0.7, patient very happy. She's ecstatic, she can read, minor details are back again, everything looks fine. And we just waited. And then here we started counseling right eye. You can see the OCTs of the right eye, and you can't even see the fovea. It's just thin retina with distorted RPE, staphylomatous eye, areas of RPE atrophy showing a very thin choroid, barely seen choroidal vessels, fibrotic lesion of a CNV. Patient said, why don't we try it? I told her I have a good experience, pleasant experience when I inject patients who would like to try. I gave her an injection and visual acuity 0.03. You can see the scans, you can see the central area. We went for the injection after the counseling, explaining that there is no guarantee of any improvement. One injection, aflibercept, first week, visual acuity of 0.13. 4 weeks, 1 month post-injection, it's already 0.3 visual acuity. And then at 6 weeks, last week, she gave me a visit and she was 0.7. Amazingly, this lady right now, you can see the right eye, the left eye, how we started CNVs in both eyes, much different starting visual acuities. And they both ended with the best corrected visual acuity of 0.7. She actually cannot believe it. And I always have these very nice surprises in myopic CNVs in the area of 80% of cases. And I've presented actually the data of myopic CNVs, and I've shown in the Euroretina in 2013 that around 20% of my cases only needed a second injection. So I really think that myopic CNVs are pleasant surprise cases, and I'm really happy to participate in this Egypt versus Argentina teams. And I actually feel belonging to both groups. I do love Argentina as my second country for sure. Thank you.
Thank you, Professor Soka. That was a great talk. And it's these are patients that, as you mentioned, we trust sometimes what they say, regardless of what we see in the OCTs. But we're going to be further discussing these cases at the end of the session. So the next speaker is going to be Professor Cristobal Couto from Buenos Aires, Argentina. He's a professor at the University of Buenos Aires, and he's going to be talking about atypical necrotizing uveitis. He's got a lot of experience, and he's the leading expert in the uveitis field within Argentina and the region, I may say. So, Cristobal, all yours.
Okay, good evening. Thank you very much for the invitation. Patricio, what I'd like to share with you today is, are two cases of atypical necrotizing retinitis. This is the case of a 37-year-old woman who started with pain and blurred vision in her right eye. She is the wife of an ophthalmologist, and they live 500 kilometers away from Buenos Aires. Her medical and ocular history was not relevant. At onset, the ophthalmic examination showed a best corrected visual acuity of 20/20 in both eyes, and the biomacroscopy revealed 1+ cells in her right eye. The IOP was normal in both eyes, and the fundus examination showed us a very mild vitreous haze with papillitis, as you can see here, vasculitis, mild vasculitis, and these very tiny, white, deep lesion at the posterior pole. The OCT confirmed the papillitis with a normal pattern of macular. And in day 2, the same features were observed, and zone 3 was free of retinitis. The visual field, as you can see, was normal in both eyes, but the fluorescein angiography revealed vasculitis, papillitis, and a focal lesion nasal to the optic nerve, as you can see here. In day 3, it was found a second lesion near to the optic nerve and multiple small, patchy, white, yellow retinal lesions in zone 2, plus a non-confluent focal lesion with healing borders, as you can see here. That seems toxoplasmosis retinochoroiditis. With these features and thinking about acute retinal necrosis, I asked her husband to bring her urgently to Buenos Aires for further diagnosis and treatment. At day 4, when she arrived in Buenos Aires, the ophthalmic examination revealed the presence of confluent lesions of peripheral retinitis in 2 quadrants. A PCR was positive for herpes simplex, and she started specific treatment with intravenous acyclovir for 21 days. She also received corticosteroids 4 days after acyclovir, and in day 22, she started with oral valacyclovir. This is day 25 after 21 days of intravenous treatment with acyclovir. Her visual acuity was 20/25. She had a few cells in the anterior chamber. The fundus showed a mild vitreous haze, and the retinitis was held in the 1 and 2 quadrants. At follow-up 2 months later on, her visual acuity was 20/20. No inflammation was observed in the anterior chamber. It remained only mild vitreous haze and no retinitis, and she was treated with valacyclovir 1 gram TID. However, she started with cystoid macular edema. That is not more common in these patients. She was treated with systemic corticosteroids, but during the tapering, the edema relapsed. So, due to the treatment failure, we decided to search other options of treatment. We found new case report papers using anti-VEGF injections with good results. This is a case of ranibizumab, and this is a case treated with aflibercept. Ozurdex was reported in 2 cases, and this French group treated a patient with interferon. So we decided to treat her with aflibercept, and this is the macular feature after the second injection. So the cystoid macular edema improved. So this is the case 2, a 47-year-old man with a loss of vision in his left eye, and he had acute retinal necrosis in his right eye 16 years ago with poor prognosis. However, this is the typical acute retinal necrosis with the necrosis, the vasculitis, and the papillitis. But what is relevant in this case is the initial presentation. As you can see here, the first day, the patient had papillitis, a focal lesion at the posterior pole with 2 smaller and deeper lesions. After 4 days, the non-confluent focal lesion showed the healing borders, as you can see here. Until this moment, zone 3 was free of retinitis. So acute retinal necrosis is characterized by peripheral necrotizing retinitis, occlusive retinal arteritis, and prominent inflammatory reaction in the vitreous and the anterior chamber. The earliest retinal lesions are small, patchy, white-yellow areas in the periphery that tend to enlarge and increase in number rapidly and circumferentially, as you can see here. This is the first stage of the acute retinal necrosis. The presence of significant posterior pole involvement is typical in acute retinal, is atypical in acute retinal necrosis, and moreover, when non-confluent focal lesion with healing borders, papillitis, and no vitreitis are found. The posterior pattern of acute retinal necrosis is atypical but not uncommon. In this paper from the Cleveland Clinic group, 44% of acute retinal necrosis patients had a posterior pattern showing poor visual prognosis and a higher rate of retinal detachment. Authors from Korea divided the 43-eye study according to the involved zone at the time of diagnosis. As you can see, 30 eyes had zone 1 involved, and these patients had worse visual prognosis, and the rate of retinal detachment was higher. In conclusion, posterior involvement of acute retinal necrosis is atypical but not uncommon. visual prognosis remains poor. Early diagnosis and prompt medical and intravitreal treatment are important. And I think you're gonna take home messages. If you don't know the diagnosis, please see the patient every day. Any doubt, consider PCR. Thank you very much for the invitation. And I love Mohamed Salah. He's the best player of the world.
Thank you. Thank you very much, Kooto. Interesting presentation. And now I have the pleasure to introduce my colleague, Dr. Teresa Kamel from Egypt. She is the head of the Ocular Immunology and Uveitis Department at the Watani Eye Center. And she's one of the best ocular immunology doctors I ever known. I mean, all over the world. This is, I think, uveitis specialty is even worse than surgical retina. And I think the patients have less expectations with uveitis patient, and Dr. Teresa is the one to throw at those cases, and she knows how to manage them, and then she sends them back to you with flying colors. So without further delay, please, Dr. Teresa, introduce us to your presentation. Thank you.
Yeah, it's my pleasure to join in this evening. My case is, the title of my case is Beneath the Haze. It's a 65-year-old diabetic male patient with history of long-standing bilateral uveitis for the past 2 years that started after a cataract surgery by 2 months. And at first he was rendered an infectious etiology, and so he was given antimicrobials, both intravitreal and systemic, with poor response. After a few months, he started to have oral steroids and pulse steroids with incomplete recovery. He had a previous workup. The patient showed unremarkable workup with a normal abdominal pelvic sonar. Are you okay? There's just a mild delay. So this patient had normal abdominal pelvic sonar, and he had a chest X-ray that showed bilateral basal diffuse opacities that were thought to be infectious. Systemically, he had no complaints, and he had a normal review of system. His vision was 160 and 260 respectively. He had no synechiae in either eyes. He had KPs that were not pigmented. He had a 1+ AC reaction, and he had vitreous haze that obscured the fundus view. We had a B scan that showed very dense vitritis. We had a CT chest that showed normal CT. There was no findings in the CT chest, and the quantiferon CBGO test was positive. We had an MRI brain, and he decided to have it without contrast because he was concerned about the contrast, and it showed periventricular arteriosclerotic changes. So the question was, what next? Interestingly, this patient developed a detachment in the right eye, and he had a partial vitrectomy that was performed by Dr. Morezi. The anterior vitreous actually showed sheets within the vitreous cavity. We had a cytology, flow cytometry, and a culture for the vitreous sample. The cytology came back positive, showing atypical large pleomorphic lymphoid cells with scanty basophilic cells cytoplasm, which is typical of B-cell lymphoma. The flow cytometry was positive for markers that were also positive for non-Hodgkin's lymphoma. The culture came back negative. So our patient is a patient with non-Hodgkin's B-cell lymphoma. So we decided to repeat the MRI brain and spine, but this time with contrast. And interestingly, he had multiple lesions in the brain. So we also have primary CNS lymphoma. Our treatment plan was intravitreal methotrexate and eye that was not vitrectomized, and systemic treatment with the oncologist in form of high-dose intravenous methotrexate and steroids. This was after the patient had gone through a few months of treatment, and we can see the fluorescein shows no perivascular leakage, which is quite typical of primary intraocular lymphoma. The fellow eye also, as we can see, shows a very decent macula, no choroidal infiltration, and the fluorescein again just showed hard disk. The patient had completed his systemic treatment and showed complete resolution of the lymphomatous lesions in the brain. So a few teaching points. When we talk of lymphoma in the eye, we're referring to either the primary vitreoretinal lymphoma or lymphoma in the uveal tissue. And the primary vitreoretinal lymphoma, which is this case, Actually, it's the extranodal type, meaning this patient has no lymph nodes and it's a subset of CNS lymphoma with initial presentation occasionally in the eye without CNS involvement. However, the uveal type is the type which affects the lymph nodes and the viscera and metastasizes to the eye through the choroid. Non-Hodgkin's lymphoma usually should be suspected when the patient is in the 5th to 6th decade of life. 80% of the patients with primary intraocular lymphoma would have CNS lymphoma, and 25% of the CNS lymphoma patients are going to have concurrent primary intraocular lymphoma. 85% of the patients with primary CNS lymphoma will develop primary intraocular lymphoma at a point. Ocular disease accounts up to 83% of the patients bilaterally. History taking is important because these patients would have behavioral changes because the frontal lobe is one of the very common sites that can be involved. Hemiparesis in 50% of the cases and ataxia for cerebellar involvement in 40% of the cases. For diagnosis, you have to have a very high index of suspicion. Cytology of an undiluted vitreous sample is the gold standard of treatment. Flow cytometry with immunophenotyping would help you detect the cell surface markers. Cytokines of interleukin 10 and interleukin 6 which show a ratio of less than 1. And PCR for gene rearrangement if your lab can have this kind of facility. Retinal biopsy is quite important, especially if you have the choroidal type of lymphoma. MRI, brain, and spine with contrast are very important because occasionally the lesions would stay within the spine before involving the brain, and a CSF fluid analysis is extremely important if you have to do it. Treatments for isolated primary intraocular lymphoma would be local treatment. For CNS lymphoma would be systemic treatment with the oncologist. However, if you have a patient with primary intraocular lymphoma not having any form of systemic manifestations, we do not have solid data that says giving this patient systemic treatment is going to prevent the occurrence of primary intraocular lymphoma. Treatment is a long array of treatments, and it's usually with the oncologist, so I'm going to just focus on what's of importance to us, and this is the intravitreal part of the treatment, which is intravitreal methotrexate and rituximab. Methotrexate has been used over several years now, and a 10-year experience has showed that these patients do quite well with the protocol of having 2 injections in the first month, then weekly injections for 2 more months, then monthly injections for 9 whole months, which is a very long protocol of treatment. This has shown to show the least amount of relapses in the eye. Rituximab has also been used because it targets the CD20 cells, which is seen in B-cell lymphoma, and has also shown favorable results, but I do not have any experience of rituximab in intraocular lymphoma because it is quite an expensive drug. And in conclusion, primary vitreoretinal lymphoma is a subtype of CNS lymphoma, and it is a masquerade. You have to have a very high index of suspicion in patients who respond poorly to oral steroids and in old age. Cytology remains the gold standard for diagnosis, and methotrexate for the eye remains the cornerstone of treatment. Thank you.
Thank you very much, Therese, for the presentation. That's a very complex case and needs a lot of thinking and working around it to manage a case like this. Thank you very much for the presentation. We have questions to be answered at the end. So the next speaker and the last speaker of the session is on the Argentina side, and is Gaston Gomez Caride. Gaston is from the south of Buenos Aires, where he works and lives now. It's a city called Quilmes. And in Quilmes, you have 3 main things. A factory that produces beer that is called Quilmes, a football club that is called Quilmes, and an eye center that is also called Quilmes. So Gaston is going to be talking about pediatric trauma and diabetes as well. Gaston, all yours.
Thank you, Patricio, for the invitation and for the Egyptian colleagues. Video, please. In this video, I'm working with constellation and ingenuity data fusion. In the ultrasound, we can see hemovitreous, retinal traction, and a retinal detachment. I always use 25 gauge valve trocars. That was the image prior to surgery. Here I am doing the vitrectomy with a 10,000 cut probe. As I said, the hyaloid management is key in this kind of patients. So I think that triamcinolone is mandatory in these cases. Here we see the triamcinolone. Also we can see diabetic vitreoretinal proliferations. I highly recommend the Alcon candle called Revolution. I love it. And I vary the forceps of LMI, Max Grip, or Saratia. Here we are relieving the retinal tractions. The next step will be the exchange fluid air. That's right. Here we can see we are with the probe again. That's right. Now the exchange fluid air, we can aspirate the periretinal fluid and the hemorrhage with the probe. The next step will be the laser pump photocoagulation. As we see, the patient have previously been pump photocoagulated. Here we can see the active aspiration, and also then we will do a passive aspiration. And finally, we are going to put silicone oil in the patient. Here is the passive aspiration. The retina has to be dry. Here then we continue with laser. And then we will put silicone oil. 60 days later, we extract the silicone oil and perform an internal limiting peel in the same procedure. We think that the internal limiting peeling in this kind of patients help a lot to resolve chronic macular edema prior to surgery and is finishing the surgery. And now we are going to pass to the second case. The boy was playing soccer and hit himself with a pipe. The reality that the patient was derived from a place in the interior of the country to eviscerate him. He's 7 years old. We can see a penetrating wound in cornea, iris protruding. We proceed to cut the iris because the time of exposure is sutured the cornea, to a cataract surgery and a vitrectomy in the first procedure. And we finally put intravitreals and subconjunctival vancomycin. Post-surgical, we apply, the patient had the retina applied, but he was in aphakia. You can see the image of the patient, but in a posterior control appears a retinal detachment. So we go to a second surgery. The vitrectomy was performed. We work a lot to get hyaloids. We use triamcinolone to make sure there are no hyaloids. Then subretinal fluid was removed. We do laser, and then we introduce silicone oils. In post-surgical control, the retina was applied, but the patient was in aphakia. I want to show you something that came with a viscous fluid pack that not many people use and know that exists. The high-speed extraction sleeve, which is placed on the trocar, and one achieves greater control and speed of silicone oil removal. can see it. The next step will be the fluid air exchange. And in the fourth surgery, we do the 3-piece intraocular lens implant. The techniques, which was the Balbecchia, the Shamani modified technique by Balbecchia, I always will tell you that the reference is that you make a scleral pocket to avoid the extrusion of the optics. At the end of the case. Thank you for your attention. And here is a picture of the retina team, or part of the retina team, with a social distance because of the COVID. Thank you, Patricia.
Okay, thank you. Thanks, Gaston, for the presentation. That was a difficult case, particularly when working with a 7-year-old patient. That makes things very, very difficult. So let's use the final minutes of this session to answer some of the questions. Some of them have been answered within the chat, but we're going to go ahead and repeat them here so we can have a bit of a discussion between the speakers. So the first question here is from Sharif Mbabi, and he says, I have noted in few cases, and this is for you, Martin, in few cases of recent giant tears with prophylactic ILM peel develop weeks after surgery, full thickness macular holes. So I don't remove the ILM in giant tears unless there is PVR. Maybe Martin, you comment.
The idea is not only on giant retinal tears, but also on retinal detachment surgery. Only remove it if it's needed to. So if we have a macular distortion in the pre or post CT, it's a good idea to remove it. If not, leave it alone.
Actually, Patricio, I have a comment here also for Martin. And I kind of had the same question like Dr. Mbabi just said. I was asking about the role of ILM peeling in those cases. Do you do it routinely in cases of giant retinal tear, or routinely in cases of phlegmatogenous retinal detachment? Because I have the same observation that sometimes some of those patients, especially the chronic long-standing detachment cases, they have thin fovea or thin macula. And when you remove the ILM, sometimes they later on develop macular holes, especially after removing of the silicone oil. It has been reported in the literature to be around the range of 7%. But do you think that ILM is indicated in all cases? And to continue the same question, you said you talked about extensive ILM peeling to the periphery. I think it's in some of those cases that you showed us, maybe ILM peeling over the areas of the membranes and the mid-periphery is justifiable, because when you're removing the membranes at those areas, there's sometimes nidus for reformation of membranes. However, there is a risk of developing of hemorrhage if you hit one of the peripheral blood vessels, and also there is a risk of creating a break. So again, the question is, when do you go for extensive ILM peeling to the periphery? In Egypt, Professor Hassan Murtada has shown us that extensive peeling should be done in pediatric retina cases, because we know those patients have extensive PVR that develop later on. But in your cases, when do you do the extensive ILM peeling? And again, do you do the ILM peeling in all cases of hematogenous detachment, or only cases with giant retinal breaks?
No, on the first question, only remove the ILM where we have a macular pucker and a retinal detachment or a giant retinal break. If the macula is okay, I don't think that it's good to remove every case the ILM on retinal detachment or giant retinal tear. And on the second question on PVR surgery, I think only to go on the periphery or extensive ILM peeling in the areas where we have scars, like the retina is not mobile, but not on the 360 degrees.
Okay.
Patricio, I have a question for Professor Mohammed. If you have some experience with the macular buckling in cases of high myopia, retinoschisis, and posterior staphyloma?
Well, I personally don't have personal experience with the buckles. We don't have the buckle available in Egypt, but I have seen cases, of course, for myopic foveitis cases, whereas myopic macular holes, they are treated by buckles Barbara Parolini have showed a series of cases. And she based her decision on using the vitrectomy or combined vitrectomy and the buccal, or sometimes buccal alone, based on the proportion of the eye and the type of the staphyloma. But I personally, I don't have the experience because we don't have the buccal in Egypt.
Yes, I read some papers that the macular buckling have sometimes better results than the vitrectomy. We either don't have available those bucklings, but I would love to try them.
All right.
I told you these are very similar countries. So whatever you don't have, we don't have either. So Rodrigo, you stay there. There's a question for you. The question for you, Rodrigo, comes from whether you, it's from Mauro Gaidofi, and it says, Dr. Santos, you usually suspend antiplatelet and anticoagulant medication in a patient with diabetes prior to the surgery?
Yes, the real thing is sometimes patients have antiaggregation that is not it's not right for that patient. They put the antiaggregation in the case of. So in case that is risky for the patient to suspend the anticoagulation, I try to work with the hematologists, and we change the oral anticoagulation to heparin, and I suspended the heparin in the day of the surgery, and we can restart the heparin in the day after the surgery, and the patient starts with the oral anticoagulation until it have the ring, the correct ring. And about anti-aggregation, I try to suspend it 5 days before the surgery, and the patient can start with the anti-aggregation the same day of the surgery.
Okay.
Patrick, a little comment, can I be a little comment, can be, about this topic?
Yep.
In our clinic, our anesthetist almost forced us to suspend that medication now, but years ago, we don't suspend it. I don't know what, but it's like mandatory in our clinic now to suspend.
No, but the interesting thing in this is a couple of years ago in AAO meeting, somebody presented a paper about of suspending the anti-aggregation or anticoagulation, and the argument was that it was life-threatening to suspend it, so the risk of hemorrhage during the surgery doesn't balance in favor of suspending it. But these cases are cases in which we are going to work with fibrovascular membranes, etc. So if I have a case of retinal detachment or a macular peeling, probably I'm not going to suspend it. But remember that many people are anticoagulated or anti-aggregated in case of. So we have to put in balance the risk that the patient is going to have suspending it and the risk of the hemorrhage during the surgery.
Okay,
I agree.
Can I ask you one last question here about the spatula you're using? You're using a retractable spatula. Is it sharp or blunt? And what is it manufacturer?
Excuse me, is it blunt or sharp, and what?
The manufacturer, who manufacture these spatulas?
Catalyst is manufacturing it. Okay. This is a blunt spatula with the tapered end and retractable spatula. So I can go down the fibrovascular membranes. I always use it in severe cases of FEVR. It helps me a lot to find a cleavage plane. And it's only one instrument, and I can work with only one instrument. I don't love to use scissors, and don't love to use forceps unless I have to.
Okay. Patricio, if I may, I have a question also for Dr. Hani Hamza.
Yes.
Dr. Hani, I've seen that case where you tried hard to remove the ILM and you failed. We know it's sometimes hard in this age group to remove the ILM. Do you think, without the presence of any breaks in those patients, is it necessary to remove the ILM? Does it help you relax the retina more? in those cases? And also, one of those cases, you left the patient on air. Again, do you think air or gas can help in those patients or not?
Well, I'll tell you. I mean, concerning this ILM debate, I believe that in these children, we don't need to release the ILM or remove the ILM at all. The ILM is abnormally adherent in patients with fever, and I have noticed this in several cases. And returning back to the ILM debate about, in cases even in giant bakes and retinal detachments, when we discovered ILM peeling, we were removing the ILM in all cases, irrespective of the pathology. And then we started to discover that it is not necessary. It may even impact the final visual acuity and may even cause harm. So we have to be very wise about the decision of removing the ILM. We can remove the ILM in the pediatric population, as we have seen in pediatric retinal detachments, but these are different eyes and the pathology is different. I believe we should not do it at all. The second question about the leaving air inside the eye, actually there was no break. I left air just to tamponade the sclerotomies in order not to get post-operative hypotony, and I leave it on 50% air, not more, so that disappears within 2 to 3 days at most.
All right. Thank you.
Excellent. I have a question here for Dr. Couto, and I would like to have Therese to make a comment as well if she can. The question is from Dr. Franco, and it says, Dr. Couto, have you ever treated a patient with acute retinal necrosis with oral acyclovir or valacyclovir from the beginning of the condition?
No, never in my life. Why? Because for me, I prefer to treat with intravenous treatment with acyclovir. But I remember one patient that I saw for the first time, and the patient had to go to the United States at the same day of the diagnosis, and I gave her valacyclovir. That the papers says that is the same thing that intravenous acyclovir.
Okay, and Dr. Kamal, can you comment? Is it something that you would normally do, or do you agree with these answers?
Usually I would go with intravitreal ganciclovir, with oral valcyclovir or with acyclovir. I would go with intravitreal. So my question also was to Dr. Couto, why didn't you inject this patient intravitreally? At least the second patient, because the second patient has a lot of confluent retinitis. I think it's I don't know. I'm in my cases I see it helps.
Yeah, the problem is the second patient lived in far from Buenos Aires, from the city, and he used to work as a farmer. And when he came for the first time, we didn't know the diagnosis, and when he came back, the necrosis was totally in the periphery of the retina. And according to the treatment, the intravitreal treatment, I prefer to use intravitreal treatment when the retinitis is completely in the 360 grades. But when we have 1 or 2 quadrants, I prefer to use intravenous acyclovir.
Thank you.
Okay, Patricio, if I may, I have a question for Dr. Suka. Ahmed, when you have doubt about the presence or absence of an actual active myopic membrane, do you rely on OCTA or on fluorescein angiography in those very high myopic patients to decide? Because in some cases, I'm really in doubt. I can see an elevation, I can see a cyst, I can see an interruption of an already very thin layer of the RPE in those patients, but I'm not sure if there is active fibrovascular membrane or not. So do you use OCTA to confirm? Do you use fluorescein angiography, or just rely on structural OCT in those patients?
Well, I'm not a big fan of OCTA, and I still feel that the what you see and interpret as a clinical fact that the CNV is there, or the response, or when to inject, I think it's still very much in the gray zone, and you can't rely on it yet. And I'm personally not a fan. But if you have a case that you cannot really decide on OCT, I think OCT is the most sensitive to catch a CNV. Fluorescein is much less so, but when you have an indefinite case, go for fluorescein angiography and try to find any clues. However, in my practice, it's the patient's recent drop in visual acuity or the metamorphopsia, and they do detect it very, very sensitively, these patients. Finally, I'll go for an OCTA, and if I'm in doubt and OCTA hints to the presence of the CNV, I will inject as a trial, therapeutic trial, improvement in vision, then says yes, the CNV was there. But in my hands, I think OCT is the best and the most sensitive, not the fluorescein and not yet OCTA.
Okay, Patricio, would you like to comment about this,
Yes.
this answer?
Yes.
And I also want you to comment about the last case that Ahmed showed, where he injected on what seemed to me like a dry retina overlying scar, and the patient still improved. Do you have any explanation for that?
Yeah, I think many of the trials, I think one of them is a mirror study or the repair. I cannot remember well now, but these trials, they looked at two ways of treating patients, whether treating according to what the OCT says or treating according to whatever the experience of the patient is. And I think that is what Ahmed is presenting here. If the patient complains of distortion or any change in vision, for me, that's a trigger enough for doing an injection, even if the OCT shows nothing. And you will see the patients coming with poor vision, myopics. They tend to be very fine and precise regarding their symptoms. And it's, come on, doing 1, 2, and 3 injections. There's no over treatment here. I'm not talking about doing 100 injections for a myopic patient.
And about the OCTA and fluorescein angiography for the detection of subtle membranes, subtle activity of the membranes?
Agree again with Ahmed. I don't trust that much the OCTA. I think it's a technology in development. Okay, useful, great images. We don't have ICG in Argentina, so we cannot use ICG. But an FA, can show you little areas of leakage there. But still, for me, when managing patients with CNV myopia, whatever the patient complains, that's the #1 reason for giving that patient an extra injection. And I'd rather do 5 and be considered an over-treater than only do 3, 2, or 1, just trying to be precise. I mean, the maximum that you can do on any of these patients is like 3 to 5 injections. So if the patient complains, I go for another injection, even if it looks like a total scar and atrophic tissue.
The problem is all our patients complain, so I'm not really enthusiastic to take their complaint seriously. However, I will try this with the next patient that comes with a scar and complaining of drop of vision and see how it goes.
Well, I mean, what we do is we talk to the patient and make sure, is this a sudden, they usually tell you, this is not the same complaint of the chronic complaint of a myopic patient. The chronic complaint is my vision is decaying, is going worse, is getting worse every day. That's not the typical complaint that we're expecting. The one complaint that I'm looking for is Monday morning I woke up and my vision was worse. Okay, so that means, take a seat, get an injection.
Exactly.
Burhani, you had a comment?
Yeah, sure.
Yes, I totally agree that we have to listen to our patients. And metamorphopsia is a very significant symptom. I have so many cases that were normal on OCT and OCT angio and complained of metamorphopsia. Following the injection, on the next day, the metamorphopsia disappeared. So the distortion of photoreceptors because of so minimal fluid that cannot be detected by OCT and even OCTA is perceived by the patients, and we have to trust their word.
All right. Thank you very much. Do you have any more questions, Patricia?
I think we have thousands of them, but we've been talking for 1 hour and 50 minutes, and I think we should release everybody and thank all the team in Egypt I hope we can, go on tour, visit you all guys, do some, these same discussion, but live, and then we go for a good dinner in a nice place in Egypt, or we can organize the same thing, you guys coming over to Buenos Aires. We will plan ahead on this, okay?
Hopefully we'll do, yeah.
Sure. We hope we meet in person one day, everyone, to welcome you in Egypt as well.
Okay.
Thank you.
Thank you very much, everybody.
Thank you.
Okay. Take care. Stay safe, everybody. Okay. Bye-bye. It was great session.
Bye-bye. Thank you.
Thanks, Patricio.